to all the people who join us. This webinar number 181, since the Andean Health Organization Hipólito Unanue Agreement started the cycle of webinars May 2020. It is already 3 years of continuous interlearning. In the Andean Health Organization Hipólito Unanue Agreement, we promote health and wellness, well as social and environmental justice. We firmly believe that the One Health approach is indispensable to achieve the highest possible level of health in our populations. Reflections on these and other priorities relevant to health and wellness can be found in the Notis Salud Andinas newsletter, monthly edition, available on the website of the Andean Health Organization. This time, the webinar that brings us together is entitled Knowing the Guillain Barré Syndrome. We invite you to leave your name, organization, and country in the comment box of the Facebook Live or YouTube Live chat. In the same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. In this webinar, we will follow the usual dynamics. We will start with the institutional greeting, followed by the presentations of our speakers, and then we will move on to the Q&A session. To access certificate of attendance, usual, in any of the chats of Facebook Live or YouTube Live, you will find a fixed link where you must fill out a brief survey and leave your data as email. Please make sure that your email is correctly written for sending the certificate, which will be sent in the coming days to your emails. To begin this important day, I give the floor to Dr. María del Carmen Calle, Executive Secretary of the Andean Health Organization, who will give the welcome and institutional greeting. Go ahead, Dr. Calle. Thank you very much, Lucho. Good morning, good afternoon, good evening, depending on when you are joining us. Receive a cordial greeting from Lima, Peru, headquarters of the Andean Health Organization, Hipólito Unanue Agreement. That's during our 51 years, have been working and is still working for health and wellness of the population from Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. We begin our webinar number 181, which will address a public health problem that has generated the epidemiological alert in Peru due to the increase of cases that, as of July 14, 2023, already totaled 201 cases and 4. Guillain-Barré syndrome is the most frequent cause of acute non-traumatic paralysis in the world, and is characterized by an acquired inflammatory polyradiculoneuropathy, frequently related to an infectious process, among which stand out those produced by Campylobacter jejuni, influenza virus, cytomegalovirus, Epstein-Barr virus, Zika virus, dengue virus, hepatitis A, B, C, and E viruses, HIV, trauma, COVID-19 virus, among others. Every year, 100,000 people worldwide develop this disorder, and the incidence of Guillain-Barré syndrome has been estimated between 0.81 and 1.89 per 100,000 in the
adulta
adult population
de
and from
0.29 a
0.34 to
1.34 por
1.34
mil
per
niños.
100,000 children.
Desde la descripción
Since the
realizada por el
description made by Guillain
2022,
Barré and Stroll
se han descrito al
list
menos 6 variedades
varieties
del síndrome.
of this syndrome have
La
been described.
polineuropatía
Acute demyelinating
desmielinizante aguda,
polyneuropathy,
AIDP,
AIDP,
la neuropatía
acute
motora
axonal motor
neuronal
neuropathy,
aguda, AMA, la
AMN,
polineuropatía
the acute sensory motor
amiotrófica
axonal
motora aguda,
polyneuropathy,
AMCAM,
AMN,
la polineuropatía
acute sensory axonal
amiotrófica
polyneuropathy,
aguda, ASAN,
AMN,
el síndrome de
the
Miller-Fisher
Miller-Fisher
y la
syndrome, and
pandisautonomía
the acute
aguda.
pandysautonomy.
La debilidad es el
Weakness
síntoma
is the most
inicial
frequent
más
initial
común,
symptom
tanto en
in
la
both
polineuropatía
acute
desmielinizante aguda como en la
demyelinating
polineuropatía
polyneuropathy
axonal
and
sensitiva
acute sensory
motora
motor
aguda.
axonal
Puede
polyneuropathy,
ser leve,
be mild,
dificultad para
as
caminar,
difficulty
o
walking,
grave,
or severe,
tetraplegia
with
total
total
e
tetraplegia
insuficiencia
and
respiratoria.
respiratory insufficiency.
En Europa y América del
In
Norte,
Europe and North
la
America, the acute
polineuropatía desmielinizante
demyelinating
aguda es
polyneuropathy
la forma de
is the most
GBS más
frequent form of
frecuente
GBS
con el
with
90%
90%
de
of
los
cases.
casos. Las formas
Axonal
axonales
forms
representan
represent
únicamente
only
el
3
3 y
to
el
5% of
5% de los
cases in these
casos en
countries,
estos países, pero son
but are much
mucho
more
más
frequent
frecuentes
in
en Asia
Asia
y en
and
América del
Latin
Norte,
America,
con
with
alrededor del
around
30
30
al
to 50%
50%
of
de los
GBS
casos de
cases.
síndrome Guillain-Barré. Finalmente,
Finally, it is
cabe
important to
mencionar
establish
que mientras más
that the
temprano
earlier the
sea el
patient is
diagnóstico,
diagnosed,
se podrá iniciar
sooner
más
treatment can be
oportunamente
started
el
with
tratamiento con terapia de
supportive
glucosa,
therapy,
inmunoglobulina y
immunoglobulin, or plasmapheresis
plasmaféresis, según corresponda.
accordingly.
Las formas graves que
Severe
llevan a la
forms that
muerte
lead
no
to
son
death are
frecuentes.
not frequent,
Sin embargo,
but
se tiene que
patients
monitorear a los
should be
pacientes
monitored
hasta su alta
until they
recuperación.
are discharged.
En caso de presencia de
In case of the presence
arbovirosis,
of arbovirosis,
especialmente
especially
el virus del
Zika
Zika,
virus,
es
it
necesario
is
monitorear
necessary
la
to
aparición
monitor
del
the
síndrome
appearance of the
e
syndrome, as
iniciar
well
los
as to initiate the
protocolos
corresponding protocols
correspondientes para gestión
for
y
the
evaluación de
management
esta
and
enfermedad.
evaluation of this process.
Este síndrome no
This
se
syndrome
transmite
is not
por
transmitted from person
donación.
to person,
Por ello es
so it
importante
is
seguir
important
los
to continue
estándares
to
de salud
properly
de nuestra población.
orient our population.
Para tratar este tema hemos
To talk
invitado
about this
a
topic, we have
prestigiosos
invited
profesionales que nos
outstanding
darán
professionals
importante
that will
información
give us important
sobre la situación
information
epidemiológica.
about the
El
epidemiological
director del Centro
situation.
Nacional de
The
Epidemiología
director of the
y
National
Control
Center of
Biológico
Epidemiology,
de
Prevention
la
and Control
CDC, doctor
of the
César
CDC,
Munaico,
Dr.
para la
Cesar Munaico.
perspectiva clínica
For
neurológica.
the neurological
Contamos
clinical
con el doctor
perspective,
Ángel
we have
Santos
Dr.
Martínez,
Ángel Santos
jefe del
Martínez,
Departamento
head
de
of the
Neurología y
Department of Neurology
Neuropsicología
and
y
Clinical
Clínica del Consejo
Neurophysiology
Científico
at the
Ortopédico Internacional,
Frank
Frank País de La
Pace,
Habana,
País
Cuba,
International
con el
Orthopedic
fin
Scientific Complex in
de
Havana, Cuba.
asesorar el
And
manejo de los
finally, to address the
pacientes
management
en
of
las
patients
unidades de
in
cuidados
intensive care
intensivos.
units,
Participa con
we
nosotros
have
el doctor
invited Dr.
Jesús
Jesus Valverde,
Valverde, médico asistente
assistant
en la unidad de
in
terapia
the neurointensive
neurointensiva
care unit
del
of the
Hospital
2 de Mayo
Médico de
National
Mayo,
Hospital
Perú.
in Peru.
Agradecemos desde ya
We
a
thank
nuestros expositores
our
y damos inicio
presenters and
al
start
presente webinar.
this webinar. Thank you very much, dear Dr. Maria del Carmen. There's the greeting of our Executive Secretary introduce myself. My name is Luis Bengolea Ore, epidemiologist, coordinator of the Andean Committee on Public Health Surveillance in the Andean Health Organization. And today, I will be in charge of the moderation of this webinar. Most studies estimating incidence rates of Guillain-Barré syndrome that were conducted in Europe and North America, and Dr. Aye already mentioned the indicators. One of them. However, the annual incidence rate of Guillain-Barré syndrome increases with age, and the older the age, the higher the risk to present this disease. To give us national information about the status of Guillain-Barré syndrome, we have invited Dr. Cesar Munaico Escate. He's a physician from the University Nacional San Luis Gonzaga in Peru, Master in Epidemiology and Public Health, and PhD in Public Health from the Uniformed Services University of the Health Sciences in the United States. He is the author of several scientific studies and journal articles, teaches at prestigious health universities in Peru, and is currently the General Director of the National Center for Epidemiology, Prevention, and Disease Control, the CDC, of the Ministry of Health of Peru. Go ahead, dear Dr. Cesar Naiko. You have the floor. Thank you, Dr. Bengolea. Good afternoon. Dr. Mariel Carmen, it's a pleasure to greet you. Well, we're going to discuss the epidemiology of this syndrome, emphasizing some important topics. The syndrome of Guillain-Barré is a syndrome that has been with us for quite a long time, up to the year 2070, where there was an outbreak in La Libertad. We didn't have much information about this syndrome. And then with a large outbreak in 2019, where there were more than 1,000 cases, we decided to study this in more depth. And in this regard, as the CDC, we carry out some studies, and we found significant information about the syndrome. And I'm going to quickly present this to have a context about this syndrome. This research that was carried out in the year 2019 was published in the Peruvian Journal of Public Health, and we were able to characterize the syndrome in a more precise manner. As you can see in this table, it affects mostly adults between 20 and 59 years. Also affects other age groups. The elderly are also affected. There's a predominance in male, and in general, the time of hospitalization was less than 15 days. We can see with a median of 11 days, but some patients could stay several days. Mortality rate in the hospital was 3.5%, and we see the mortality in the age groups, and this was more prevalent in those over the age of 60. We can estimate the incidence and mortality rate with this study, and we see that the incidence rate was higher in the elderly over the age of 60, and also is higher in males. Here we have the years that we studied, and we can see that the distribution of incidence and mortality stays the same at the time. Another important finding that was key to establish a baseline in 2018 and 2019, and following the analysis of hospitalization, we estimated the cases for 2018 and 2019. As you can see in blue with the confidence interval, in order to compare them to what we are in 2018, 2019. This distribution of Guillain Barré are mostly in the coastal region, in the north coast and Lima. See, this is 2015, 2016, and 2017. The distribution of cases, and also some areas of the highlands, but mostly in the coast where we saw the most cases, and the other regions that are affected are Junín, Cajamarca, that show a significant number of syndrome. So this is what the background information of what we saw in 2018, 2019, and 2020. Now we're going to look at what happened in 2019. In the month of May, there was a significant increase in the number of cases of Guillain-Barré syndrome had never seen before. That was way above what we were expecting for the country. As I mentioned, we had already made the projections. See, black line was the observed cases, and this green line showed what we observed. There was a significant increase in the number of cases, almost 600 cases in these during the outbreak. Cases were located in several departments throughout the country, such as Lima, and were distributed in several areas in Lima, but mostly in some highly populated areas. In Junín, the same, mostly located in the city of Huancayo and Tambo, the areas with the highest concentration of cases, and in La Libertad, in El Porvenir. There were other areas affected, but that was the hottest zone. Same was seen in Piura, in the capital city of the department, and in Lambayeque, mostly in Chiclayo, as well as Cajamarca. As you can see, these are the curves for Lima, Junín, Piura, Lambayeque, Cajamarca that we observed in 2019. You can see this outbreak had a rapid increase, 0.32 daily growth rate, increase rate, and the drop was quite slower until we achieved to the expected rate as previous years. It is important to consider that this outbreak lasted 4 weeks, with a sudden increase and had a rapid speed of growth. In this outbreak, mostly adults were affected, and also the elderly, and the patients reported having had a respiratory or gastrointestinal infection in the last 4 weeks. And among the cases that we saw, the cases presented flaccid weakness of limbs. Also, there was an ascendant and descendant paralysis. Mostly was ascendant, mostly of the Aman subtype, with 64%. And there were also some impairment in the spinal fluid. On the other hand, the uncertainty criteria were with criteria 3, 2, if they had some cytological dissociation or electromyography, and with criterion 1, with both tests only 8.8%. That is important to consider. But of course, in this investigation, this was an outbreak of Guillain Barré. The other important topic in this outbreak, what caused this, or what was the trigger? As you can see, in all the regions, there was a predominance of the Aman variant. And this is the mortality rate in 3 to 5%, which we observe in our. In that search, we're looking for what was the triggering for the Guillain Barré. We did an epidemiological analysis where we saw that before the outbreak of Guillain Barré, there was increase in diarrheal diseases in all the regions. And we also did spatial analysis where we were able to demonstrate that there was a higher probability of finding cases of Guillain Barré in the districts where there were more incidents of diarrhea. So this was giving us an idea of what could be associated with diarrheal disease, but what diarrheal disease was also important to know what type of this diarrheal disease. With this history in the cases of a man that is related with Campylobacter jejuni, the hypothesis was that this was the cause, Campylobacter. Then we had to demonstrate the infection rate and contamination, what foods or water sources were contaminated and related with this Campylobacter infection. That following the infection with Campylobacter, they could develop the Guillain-Barré syndrome. So we did several studies, both in poultry and also in markets with poultry. We took samples from the poultry, so we could isolate the Campylobacter. And we found Campylobacter jejuni in patients with the ST2993, which is associated to an increase in Guillain-Barré, and this was found in the samples of chicken or poultry. This will confirm that Campylobacter was causative microorganism that caused this condition, and this Campylobacter share some character with the Campylobacters found in other regions in the world. So Campylobacter is a zoonosis. The blood animals have it present in their digestive system and may contaminate water or by consumption of these animals that are not adequately cooked, because Campylobacter can be eliminated with heat, and this may produce some outbreaks. It's important not only poultry, but also other animals are reservoirs for this disease or this agent. Pigs, bulls, dogs, cats, birds, rabbits. This information, we did an intervention. We coordinated with the mayors of the cities and poultry growers who had national distribution of poultry. We decided for this intervention to make this food safe. But then we had the COVID-19 pandemic. Guillain-Barré outbreak was followed in 2020, at the beginning of 2020. Then we had the pandemic, and we went back to the pre-pandemic levels. And up to now, at week 24, as you can see, there's been an unusual increase of Guillain-Barré in some regions of the country. It was expected because after the pandemic, the conditions returned to normal. During the pandemic, there was confinement, hand washing, but when we went back to normality, uh, risks were once again present. We saw an increase in the cases. Precisely 2 weeks before the increase, we were discussing about this topic in order to establish the surveillance for Campylobacter and start working prevention. And 2 weeks later, we saw the increase. Increase of cases. You can see that the same areas that we had Guillain Barré in previous years, Cajamarca, Callao, La Libertad, Lambayeque, Lima, and Piura. These are the regions where we currently have the outbreak, but also the regions that contribute to a large extent to Guillain Barré symptoms throughout the country. So let's see what happened with 2023. These are the cases of 2022, 2021, and this increase of cases obviously generated an alert and intervention by the CDC and the Ministry of Health. Basically, these are the regions that I mentioned, Lima and the north area of Peru with Piura, Lambayeque, Cajamarca, and also Junín to a certain extent, which presented the increase of cases, but it's mostly in Lambayeque and Piura, which are where we started seeing the outbreak, and also Lima, capital city. So the heat map to show the behavior in the regions that generate a larger number of cases, Piura, Lambayeque, La Libertad. In the week 23, 24, is where they show an increase in the number of cases. And the same for adults are the ones who present this disease with more frequency in males, and they have a history of respiratory disease and gastrointestinal disease. The studies for cases, most of them had a history of consumption of chicken or animal or food related to Campylobacter. Show you the time between they are exposed, either respiratory or gastrointestinal conditions, and then when they develop the syndrome of SGB, approximately 7 days between they are exposed and they present the symptoms. And characteristic weakness, bilateral involvement that is symmetric in ascendant progression. Also, there's a decrease or absence of osteotendinous reflex, hypotonic muscular tone, and in general, most of them are Brighton level 3, but we had a larger percentage of those with Brighton level 2 because they had spinal fluid and also the clinical symptoms. This is a preliminary analysis. There's a predominance of AIDP with AMAN, Immunoglobulin is a treatment of choice, but we also use plasmapheresis, are equally effective, and we have what we have accumulated in this year, we have 4 deaths, but in this last increase there has been no death, but these 4 come from previous months. We also analyzed from the epidemiological perspective the increase of cases of diarrhea before the increase of Guillain Barré, both in Piura, Lambayeque, and La Libertad. We saw the same as the previous outbreak. We took samples to those reported cases, of which 59.1% were positive to Campylobacter. So the INS has also done the genomic analysis, and it's the same 2993 ST Campylobacter that produced the previous outbreak. In that regard, we issue an epidemiological alert so the services can respond adequately, so the ministry can generate the necessary resources to treat cases. Here, we have to work in communication, intervention, hand washing, the thermal treatment for food,
la leche hervida o pasteurizada,
boiled
el
milk
lácteo,
or
es
pasteurized
algo que
milk,
es importante.
consumption
Y
of
la
boiled
tercera,
water.
estamos trabajando
And in terms of interventions, we're working on good practices
alimentos, ¿no?
for production and, and trade of foods
de peligros y puntos
and
de
the
control crítico y la fiscalización,
HACCP
obviamente, de lugares
as well of controlling in
en malas condiciones, ¿no?
areas where they sell
Esto es un
foods.
poco el esquema que nosotros tenemos de
This is
trabajo
the
para este
working
tipo de brotes.
schedule for this type of outbreaks.
Vigilancia
We
centinela,
implement sentinel
Campylobacter,
surveillance
identificar
for
las rutas de
Campylobacter,
transmisión de
identify
Campylobacter,
the possible routes of
tratarlas
infections,
al beneficio
identify food
para que
habits
no
of those
el
patients
síndrome
affected
de
with this
Campylobacter y también
syndrome,
que pueden estar implicados pues, como detonante en el síndrome de Guillain-Barré, identificarlos y
and
también
to
comercializarlos
identify
como
the
medicamentos.
sales channels
Se
and
trabaja cuando hay
food
estos brotes
production
con estos
areas,
mecanismos de
and to
contaminación de
identify the
alimentos
possible
y
mechanisms of
evidentemente
contamination of
control de
foods,
Campylobacter
and to
cerebrales.
identify the circulating
Todo
Campylobacter
eso
strains.
se ha trabajado en este
All of this
momento
has been worked during this outbreak,
obviamente llegó a la
and
conclusión
we
que eran
arrived to the conclusion that it once again
Estamos,
Campylobacter. What do
algo
we
de esto
expect
obviamente
for coming weeks? There's an increase in
disminución,
2023,
como ustedes ven acá, que
it's
es
almost in the same
brotes
period
anteriores,
as seen in
y la
2019,
característica de los brotes anteriores que
and the
obviamente eran pues
characteristic of the previous
más largos.
outbreaks last
Y
no more
esto
than
en este
4 weeks.
momento
This
se
increase
presenta igual en 2019
is
y
similar
2020,
to
probablemente
2019 and
se
2020, so we expect
se
that this
resuelva
outbreak is going to
en estas semanas que vienen
solve in the coming weeks.
y bueno, volvamos a
We will
los
go back
niveles usuales.
the
Pero
usual
se debe
levels.
trabajar
We
de
need
manera
to work
multisectorial, no solamente se trabaja en
multisectorial
países.
effort, not only from
Para
the Ministry
terminar,
of
se
Health,
generaron escenarios,
to
¿no?
if we have generated
Estamos ahora
scenarios,
en el escenario
we're
más
now
bajo,
in a low
es un escenario moderado y
scenario,
severo,
moderate or
y aquí son
severe,
los casos
and these
esperados
are the
en este
expected
escenario
cases
severo para poder
with some
epidemiológico,
modeling.
¿no? Entonces, en función a cómo va
So in
evolucionando
terms
esto,
of how
vamos a
this
poder ver
evolves,
si se pasa
we will be able to
al
see
escenario
if
más
we
grave o
go to
severo.
the
Pero
next
lo más probable es que nos quedemos
severe
en
or
bajo
moderate
o moderado,
scenario
¿no? De acuerdo al número de casos ya
according
notificados
to the number of
hasta el momento,
cases
¿no? Y ya vemos que ya en
reported
México
so far.
todavía hay casos,
And we see that we
no
still
son de
have
la magnitud de la
cases,
semana
but not as a
pasada,
magnitude
¿no? Y por
of
otro lado, la tasa de
before.
letalidad ha
And the
sido similar a otros
mortality
periodos,
rate
¿no?
has been
Estamos
similar or less than
esto
reported
es
in
lo que les
previous years.
quería
So
comentar
this is what I
en
wanted to
esta
comment
presentación
very
sobre la
quickly
influenza.
during my presentation about Guillain Barré. Thank you very much. Excellent, Dr. Cesar Monaico. Very excellent description. It's important to highlight that this Guillain-Barré syndrome has been studied since the year 2014, going to 2017, and you presented some special characteristics such as uh, the presentation in the coastal regions and some areas in the highlands. It was associated or had a mortality of 3.5%, and it was higher in the elderly. The most affected group was between 20 to 29 years of age, and in the year 2019 there was a significant outbreak that was studied, and we established the presence of Campylobacter jejuni associated to many patients, and also the presence during the follow-up of poultry and domestic animals. In the recent outbreak, we should mention that we have identified two variants that are still under analysis, such as the acute demyelinating polyneuropathy and the acute axonal motor neuropathy in the year 2014 to 2017. This Dr. Monaico, we invite you to stay in the room so we can go to the Q&A session that we have in large number at this moment. Thank you, Dr. Cesar. And now we move on to the next presentation. An emergent relation between Guillain-Barré syndrome and acute infection by arbovirus, including Zika and chikungunya, is being monitored closely and is a subject of great interest as the global epidemic spreads. The case control epidemiologic surveillance will precise the incidence data of the arbovirus associated with Guillain Barré syndrome. Now I would like to introduce Dr. Ángel Santos Martínez. Dr. Ángel Santos Martínez is a specialist second-degree neurology, a member of the Cuban Society of Neurology and Neurosurgery, professor and assistant researcher of the Neurology and Clinical Neurophysiology Service of the Frank País International Scientific Complex located in Havana, Cuba. Go ahead, dear Dr. Santos, you have the floor. Good afternoon. Can you hear me? Yes. Go ahead, please. Well, I would like to very thankful to my colleagues for inviting me to participate and to provide some of our experience in this important event. The topics that I'm going to bring you are interesting finding that we have accumulated in our experience when we fight against the cases that we've seen related to arbovirosis. That we can say that the outbreaks that have affected us most before COVID-19 and after COVID-19 last year had an outbreak of dengue virus. These arboviruses can be considered as endemic diseases in our countries. We see in many other countries in the Americas, Asia. These are the topics that I would like to share with you. Frequent neurological syndromes, the arbovirosis, some elements of pathophysiology or the hypothesis of the neurological lesion, the diagnostic criteria that should be used to diagnose these patients, the complications by the Guillain-Barré syndrome that are more prevalent, and some general aspects of how to treat and follow this Guillain-Barré syndrome. Well, arbovirosis, these are the general characteristics. Just to highlight, from the clinical point of view, they produce viral infectious syndrome, very similar clinical manifestations characterized by headache, fever, myalgias, joint involvement. All of these in the course of an acute febrile syndrome, usually self-limited, and there may be more severe cases of this condition with complications that can threaten life, among them Guillain-Barré syndrome. And the most interesting thing is they may have co-infections in cases where there's a coexistence of arbovirus with other infectious diseases such as respiratory or just gastrointestinal infections. And this is transmitted by the Aedes mosquito, but there's some research, recent research that it seems that this is not the only mosquito that may transmit it. There are other mosquitoes involved. A causal relation between Guillain-Barré and this arbovirus is not new. Since 1990, we knew that one of the first reports of cases of Guillain-Barré related to dengue virus. And from that year, with different outbreaks in several regions throughout the world, they were reporting several cases. It's an epidemiological alert in 2018 issued by the World Health Organization following an outbreak in 8 countries in the world. One of them in the Americas, where they saw a large number of cases of Guillain Barré related to Zika virus, in addition to other congenital malformations such as the WHO issued a number of measures they need to consider for diagnosing the cases. So this tells us about the relation between Guillain Barré and arboviruses. Dengue and chikungunya is a relationship that we've seen and studied with many cases in recent years. What is Guillain Barré? Guillain Barré is a condition where we see an inflammatory process of the peripheral nerves in all the proximal regions of these nerves. So it's called polyradiculoneuropathy, inflammatory acute polyradiculoneuropathy, and around 98% we're going to see that is self-limited, but they have reported some cases of recurrent condition. It is well known that this inflammatory process demyelinating in most cases, but there may be cases we don't see this damage on the axon is mediated through autoantibodies. These autoantibodies are going to join to some elements of the complement system in an inflammatory cascade. They're going to produce damage in the myelin sheath in the nerve and the axon. We see one of the studies that were published in 2012 in Japan, where they indicated all the clinical events as well as infectious events that can precede the syndrome Guillain-Barré. Not only respiratory or gastrointestinal diseases, but we can also see Guillain-Barré syndrome following vaccination, organ transplantation during a cancer process. And Campylobacter jejuni has been of the agents more studied. And we're going to talk about the pathogenesis of this syndrome with relation to Campylobacter, but we also have some other agents such as influenza A, cytomegalovirus, HIV, Epstein-Barr, Mycoplasma pneumoniae, Haemophilus influenza. This same author was one of the first authors that described, because they talk about these antibodies and these antiganglioside antibodies. So some studies that have been published with these outbreaks of Guillain-Barré in relation with Zika virus and dengue virus and chikungunya virus. And these are studies that show the relationship association. In a Peruvian study published that was interesting, that we studied and analyzed in depth, because they made a very exhaustive analysis of the viral infectious etiologies that Cesar has already mentioned. And in this paper, they mentioned the enterovirus, one of the organisms that was suspected with a causal relationship with these outbreaks in 2018 and 2019. And it was very interesting to find, because a review of the possible of the large spectrum of infectious agents that we need to consider when we treat a patient with Guillain Barré syndrome.
Bueno, ¿qué es lo que ocurre en realidad?
So what happens in this
Cuando el organismo se pone
when
en
the
contacto con
body is in contact with
gérmenes,
some of these microorganisms,
se va a
specifically a
desarrollar una
virus,
serie de respuestas
they develop
inmunológicas
a series of
que
immunological response
en estos
where epitopes are created. These are fragments of macromolecules or
en el caso de los
proteins.
arbovirus, se ha
In case of
centrado mucho
arbovirus, they
de la
focus
proteína NS1,
on the NS1
una viral
protein,
no
which
estructural,
is a viral
que puede
non-structural
ser
protein
una
that
de las
it
que mayores
seems
propiedades
to be
antigénicas.
have
La
antigenic
cuestión es que el
properties.
organismo va a crear
The
anticuerpos
body is
contra
going to
estos
create
epitopes,
antibodies against these
los cuales
epitopes,
los reconoce como antígenos,
which recognizes as antigens.
y hasta ahí, bueno, todo
And
bien.
so far,
Lo que
everything is
pasa es que
fine. But what we see
epitopes
then is that
y
these
estas
epitopes
estructuras y estas
and
macromoléculas
these
que tienen función
macromolecules
antigénica van a
of
tener
antigenic
rasgos
function
moleculares
are going to have
semejantes
molecular
a
similarities
algunas glicoproteínas
with some
y algunas
proteins
proteínas de membrana que
and
se
some
encuentran
membrane
en el
proteins that
axón
are found in the
y en la
axon
vaina de
and in
myelina.
the myelin
Y
sheath.
esto es lo que va a
And this
desencadenar por un fenómeno de
trigger
modificación molecular
these
el daño
phenomena
de la mielina o el
damage
axón.
on the
O
myelin
sea,
or
los mismos
axon.
anticuerpos
So those same
se crean
antibodies
a
that
estos
the body
epitopes
creates
son
for
los que
those
van a atacar.
epitopes are the ones who are going to
Y de
attack
ahí que las
structures.
formas clínicas que vamos a tener
Therefore, the clinical presentations
precisamente
are
relacionadas
going to be precisely
con
related
dónde es
to
que se va a producir el mayor
where
daño.
is the
O sea, si
worst
un
damage
número de
generated.
anticuerpos está
Most
dirigido
most
contra
antibodies
de la
are
mielina,
directed to myelin.
entonces vamos a tener las
We're
formas
going to see
predominantes
is
de la
demyelinizating
polineuropatía aguda
forms of
generalizada, o sea, la IDP más
AIDP,
frecuente,
which is more
¿por qué?
frequent,
Porque
but
estos anticuerpos van a atacar
these antibodies
los
attack
angiócitos que están en
gangliosides
el axón, y los
in the
neurones de
axon,
Berger. Se han identificado varios tipos de gangliósidos,
and we have identified
sobre
certain type
todo
of
los
gangliocytes,
más relacionados que se han
those
podido estudiar con
related
las
that have been
arboriviruses en
studies with
Zika
arbovirus
y
and
dengue han
Zika
sido
and
el
dengue
GA1 y el
have been
GD1A,
the
pues
GN1
se
and
van a producir
GD1A.
variantes
We're
axonales
going to see
que
the
suelen tener
axonal variants
un
that
tipo
usually
diferente
have a
en
different
cuanto a
course
gravedad y
with
severidad
regards to
de los
severity and
motores
seriousness
síntomas
of
que
the motor
presentan.
symptoms that they
Esto, digamos
present.
que es más o menos una explicación
This is
porque
sort of an
varios de estos
explanation of why we
clínicos
have these clinical variants.
nosotros hemos visto
And
muchas
we have
veces
seen many cases
presentan un
where
daño del axón como de la
the
mielina
axon, we can have
poco
both
difícil de
conditions,
diferenciar.
and it's difficult to make the
Hay
differentiation between
que
the two.
señalar
We
que
need to
no en
point
todos los
out
lugares
that not in every
nuestros
place
hospitales,
or
nuestro
our
país,
hospitals or country
nuestra región,
or the countries of the
tienen los
region,
medios de laboratorio
we have the laboratory
para hacer
means
las titulaciones de estos
to
anticuerpos,
make the determination
más
of
bien
these
lo sospechamos
antibodies.
por las
We
manifestaciones.
suspect them following the clinical
Uno,
manifest and
revisando publicaciones
by reviewing
de
publications
autores en otras regiones
of
donde se
authors from other
tiene
regions
el
where
acceso al
they
estudio
have access
anticuerpos.
to the antibody
¿Cuáles son las
determinations
características
studies.
principales de esta
What are
enfermedad?
the principal
Bueno,
characteristics of these
cuando
diseases?
comienza
In most cases,
la forma más
starts
clásica, que es la
the classical way
polirradiculoneuropática
with
de
this
degenizante
polyradicular
es un
neuropathy
síndrome que suele caracterizarse
syndrome that is
generalmente por
characterized by
parestesias, trastornos sensitivos que
paresthesias,
pueden comenzar en las
sensitive
regiones lumbares,
impairment in the lumbar
los miembros
area,
inferiores,
going to
y a
lower
los pocos
limbs.
días de comenzar estas
A few
manifestaciones,
days after these
el paciente va a
manifestations,
comenzar con
the
una
patient is
debilidad
going to
muscular
have
que
a
suele ser
muscle weakness
bien asimétrica,
that
que
is
suele iniciarse por las regiones proximales de los
starts in
miembros
the
inferiores,
proximal areas of the lower
con
limbs,
dificultades para
the
incorporarse boca
difficulties
abajo, subir
to
escaleras,
stand
caminar.
up and to climb stairs or
Una
walk.
de las características
And
clínicas
one
más
of the
importantes,
most important clinical characteristics
inclusive desde estos primeros días,
from these initial days that they start with
vamos a
these
tener
symptoms,
reflejos
we're
musculares
going to have
profundos,
an
reflejos osteotendinosos,
impairment
lo
of
cual
deep
para nosotros
osteotendinous
neurólogos tiene
reflexes that
mucha
for us
relevancia
neurologists are extremely valuable
en el diagnóstico de estos
for
síndromes.
the
Y
diagnosis.
además, va a ser una enfermedad que se va a presentar como un
We're
síndrome
going to
de
see this
cicatriz aguda,
as
simétrica,
an acute
con
symmetric
afectada toma de los reflejos
involvement
musculares,
with
un tipo
severe
de parálisis
osteotendinous
que
reflex
tiene las
impairment
características de ser una
and a
parálisis
paralysis
simmétrica, o sea, una
that is,
parálisis con flacidez muscular. Es una enfermedad que
this is
generalmente
a disease
la
that
progresión suele ocurrir
has
en
a progression in few days or weeks. Monophasic disease has a progression phase, stabilized, stable phase, and this progression phase is usually lasts between 2 and 4 weeks, in most cases, between 14 and 21 days, and following this phase, the patient goes into a period of clinical stability with no more complications and going to have an evolution to convalescent stage. However, we're going to see that a large number of patients, approximately 50%, the paralysis can affect other regions of the body, with cranial nerve, with the facial nerve. It may affect oropharyngeal muscles, and other ways of presentation may be facial paralysis and tracheal paralysis, where it involves both facial nerves and the oropharynx, and with the proximal lower limbs. These are clinical values that we can see at the beginning of the paralysis. We're going to see, and in some of these patients, the complications that may develop is autonomic dysfunction that can be severe. In many cases, it's one of the main causes of the patients can die. One of the most important characteristics of this syndrome that in most cases is going to present in the post-infectious state. Once the acute phase is over with this infectious fibrotic disease, between 7 and 14 days following, is that we see this, after this viral acute disease, we see the appearance of or emergence of Guillain Barré syndrome. But in some cases, they may be close to each other. For us, the diagnosis of Guillain Barré is mostly clinical. The criteria of the spinal fluid and the electrodiagnostic methods are criteria that support the sensitivity and certainty of diagnosis. The diagnosis of Guillain Barré is mostly clinical, with some well-established clinical judgment, because we're going to see that in many cases, the alterations of the cerebrospinal fluid that support the diagnosis is an elevation of proteins with the absence of cells, with this dissociation of albumin and cells, are not present in all cases. For us, the electrophysiological impairment of the nerve are useful to make the diagnosis in early stages. And one of the characteristics that we see is a slowing of nervous conduction with blockage in more than 2 motor nerve explorer. The absence of the F wave or the increase of the latence of the H reflex are electrophysiological parameters that we use in these cases and are extremely valuable in an adequate clinical context to confirm the diagnosis. We already have mentioned the Brighton criteria for the definition of the clinical syndrome of Guillain Barré. These criteria have been used by the WHO, was issued following the outbreak in relation to the Zika virus. And these are the criteria that have been used so far for the design of epidemiological studies. These are criteria that we believe that are quite adequate, have a high degree of sensitivity, and after those authors rather to use other criteria. But we're going to see importance of these criteria, that the diagnosis can be established in three diagnostic levels, and these diagnostic certainty levels are established, and there is a corroboration with clinical manifestations and the findings in the CSF, and also the electrodiagnostic alterations that I already mentioned. There are some elements that I would like to share with you that we use in order to make an adequate diagnosis. This is one of the diseases where we cannot afford to miss the diagnosis. In many cases, in the first week of the symptoms, this albumin cytologic dissociation may be normal. That is, a patient comes to the ER with this syndrome, with a deep involvement of reflexes, few days of evolution, and the lumbar tab reveals a normal CSF, because this can be seen in a large percentage. Now we're going to see that in 10% of cases, through the course of the disease, may have these normal levels of proteins in the CSF. And as I mentioned before, the electrophysiological abnormalities are going to be approximately 90% of cases, not only in support of diagnosis, but also for the prognosis with the severity, damage, and that is very important to issue a prognosis at mid or long term. Some of the clinical variants that have been mentioned with the Guillain Barré syndrome, acute axonal motor neuropathy, Miller-Fisher syndrome. There is an acute dysautonomic variant. We haven't had much experience with this case. And there's also a sensitive form with a more attack to the dorsal root ganglia. And these clinical presentations have been related to anti-ganglioside antibodies. For example, AIDP is related to antibody GM1, very molecular similarity to Campylobacter jejuni. And the Miller-Fisher syndrome is related to antibody GM1B. And some characteristics that I'm going to show you later. The Fisher-Bickerstaff syndrome is quite interesting. Present, it is considered as a syndrome that may be clinically characterized by ataxia, ophthalmoplegia, paralysis of the nerves that have to do with ocular movement, loss of reflex, and in many cases there may be an involvement of the brain stem. We're going to see that at present we talk about this anti-GQ1B syndrome, where we see the Miller-Fisher syndrome with some variants of this Guillain-Barré syndrome, because in this syndrome, the changes in the CSF and the electrophysiological impairments are similar to the classic SGB, and all indicates that in this syndrome, the attack is not limited to the peripheral nervous system, but also affects an inflammatory attack in some regions of the central nervous systems in the brain stem specifically, because those anti-GQ1B antibodies are also found in the brain stem and some other components. And the same treatment of the classic Guillain-Barré syndrome, although some authors have suggested that in these cases, we have Fisher-Bickerstaff syndrome, it would be prudent to use steroids. We had experience with some cases in children and in adults, and we start using steroids. We always have the fear that they may produce some respiratory distress, but there's some other study that support the use of steroids. So there are not many results, but in this form, where they may be an important involvement of the brain stem, we can consider this alternative. And we've seen some results with brainstem involvement with this Fisher-Bickerstaff encephalitis, and steroids may help. Some images where there is a significant involvement in the brainstem and with mutation affection at this level. And this is the flare with MRI, where we see the lesions in this demyelinating severe inflammatory process, the lower part of the pons. And we should not be very careful with these cases. Watch them very closely. So these elements can make us doubt about the diagnosis. When the muscular weakness is quite asymmetric and strong, when there's a presence of a sensitive level, when there's a vesicorectal involvement in the initial portion of disease, in the presence of meningeal signs, the subacute progression of more than 4 weeks of the symptoms, we will not be talking of Guillain Barré. We're talking about another entity, which is a polyradicular neuropathy. And it coexists with concomitant febrile disease. But as I mentioned before, there's some case reports where there may be some overlap of these two phases, but that's not what we usually see. Usually presents several days after the febrile portion is over. In terms of treatment, I'm just going to talk about some general aspects of the general and preventive measures for all patients who has this condition. We follow a protocol in Cuba. All the cases are admitted to the intensive care unit, regardless of the severity of the clinical presentation. And we start treatment with immunotherapy as early as possible. This is a guide from Argentina. It's quite interesting, quite recent, where they establish how to approach this problem in 10 steps that we think that is extremely valuable. And the truth is that in terms of specific treatment for this disease, although there's a lot of debate, the immunomodulating treatment is the one that's more promoted at this time. Scientific evidence based in several clinical trials, and with the use of intravenous immunoglobulins, we use immunoglobulin as well as plasmapheresis that are effective for the treatment of this disease. There are some points that can be debated if ictaglobin or plasmapheresis is more effective. So far, both seem to be quite effective, similar in terms of effectiveness. We're always going to use one or the other depending on the availability. There are some centers that can carry out plasmapheresis. We in Cuba, we use imtaglobin because we don't have the option for plasmapheresis in all of our hospitals, but both alternatives work, and they will indicate. We have discussed what would be effective if we combine intaglobin with plasmapheresis, or steroids may be effective at some point. At this moment, there's nothing that suggests that a combination of these therapies is more effective. But when they're used alone, the use of steroids of methylprednisolone for Guillain-Barré is not well accepted. There's no data that support this. We don't use it on a routine basis, Guillain-Barré, except in the cases that I mentioned, where there's involvement of the central nervous systems, specifically the brain stem. And we have used steroids with very good results. Steroids alone are not going to fight the course of Guillain-Barré syndrome, and we do believe that the earlier the treatment is started, between the first 7 to 10 days, the better is going to be the efficacy of treatment. It is important to point out that this treatment is not a specific curative treatment. It's a treatment of going to interrupt the course of the disease and to prevent that there is a accelerated progression of this disease. This is what we've seen with the treatment with immunotherapy or plasmapheresis. The prognosis, we're going to see that there are clinical elements that speak in favor of a good prognosis with early ages, with there's a low severity of neurological involvement. Patients who have a very quick clinical evolution of few days, those are you need to be careful with those cases that we call red flag, that are patients who have an elderly age. But a poor prognosis is the, as I said, the elderly, the extreme ages of life, and the concomitant severe diseases such as ischemic cardiopathy or COPD or diabetes mellitus. And the respiratory involvement, if it's too very early in the disease, is one of the symptoms that we explore in these patients. From the moment that the patient comes to the emergency, because patients who show involvement of respiratory organ present more complications and require mechanical ventilation and ventilatory support. Those patients who have a slow recovery period in more than 4 weeks are also have a poor prognosis. We have seen, and it's been reported, that axonal variants may have a worse course and more disability because of the relationship in the paralysis, and the forms are more severe, and patients are left with more disability and complications. Regards the evolution of this syndrome, it has a monophasic course. However, we're going to see many cases have this progression. Up to 50% may require to go to the ICU with ventilatory involvement and dysautonomy to 20%. The ways in this oropharyngeal weakness predominant are those who may have to use intensive care unit, but 10% can have some disability, especially the axonal forms, and we always have to consider some of the complications that are reported, such as hyponatremia with inappropriate secretion of antidiuretic hormone, and other complications such as pneumonia associated to the ventilation, cardiac arrhythmias, thromboembolic disease, digestive bleeding, or paralytic ileus. There are other neurological syndromes related with dengue and Zika, acute encephalopathies, encephalomyelitis, encephalitis, is the effect of the virus in some of these areas. Acute myelitis and acute myositis is that we saw and published. You see the severe involvement of the white matter, involvement of the left hemisphere, this large area of involvement here, here, and here. And in these cases, this is different to the Guillain Barré syndrome, acute disseminated myelitis, is related to this arrovirus and is produced by the same mechanisms that the attack is going to be more on the white matter and in the central nervous system. This is a case that we reported of non-progressive multifocal leukoencephalopathy following dengue virus. Has been reported in the Americas in Colombia. I show you this because the context of an epidemic need to consider these options where we see a Guillain-Barré can have these good manifestations. And there will be a coexistence of these neuroinflammatory syndromes. And to conclude, in endemic areas, we who face this type of patients, we need to keep in mind this nervous system diffuse demyelinating condition, and diagnosis is mostly clinical, supported by electrophysiology and CSF studies, and both plasmapheresis and intravenous immunoglobulins are treatments that are more effective to accelerate the recovery. And the earlier we start, that we make a diagnosis and start treatment, we're going to have better results. And always there are these clinical variants that must be kept present so we don't make mistakes. These are the things that I wanted to share with you. And this finishes my presentation. Thank you, dear Dr. Santos, Ángel Santos, for your excellent presentation that we can summarize in the experience that Cuba has had with regards to the presence of arboviruses and the possibility of having the presentation of Guillain Barré, something that is important to highlight during your presentation, the relationship of treatment and outcomes. And you indicated that using plasmapheresis and or immunoglobulin provides the same result. And this is excellent information for us. Another important, you mentioned the use of methylprednisolone doesn't add up to the final outcome and the combination of those two treatments. Also, you also mentioned the prognosis for a patient who has Guillain-Barré syndrome, much better the prognosis when it's in early ages, that is not as severe from the neurological point of view, and the more acute, between 1 and 3 weeks is good, but not hyperacute as 1 to 3 days. And finally, when the recovery is quick during 1 week, the prognosis is better as opposed when the disease affects the elderly and have other comorbidities. Finally, the suggestions and recommendations to study other diagnostic options with, with the outbreaks of Guillain Barré are very important. Thank you, dear Dr. Santos. Once we conclude the presentations, we post in our webpage the presentations. So to you, Dr. and Dr. Munaiko, appreciate if you could send us your presentations so we can post them in our webpage so other people can review them, review this information. Thank you very much, Mr. Doctor. And now we invite Dr. Jesus Valverde. Dr. Valverde Guaman is a physician of the Universidad Nacional San Luis Gonzaga de Ica with a post degree in second specialty in intensive care medicine. He works in the Guillermo Almenara National Hospital Enfermedad de Salud. He has a master's degree in health services management, teaches topics in the specialty of intensive care medicine, and has been an organizer of several scientific effects. And since 2014, he serves as an assistant physician level 3 in the neuro-intensive care unit at the Hospital Nacional 2 de Mayo in Peru. Dear Dr. Valverde, welcome. You have the floor. Good afternoon. Thank you very much for your introduction. I work in Hospital 2. Now I'm going to present the severe forms of Guillain Barré. This is a syndrome that we see quite frequently in the intensive care unit. Approximately 20% of cases of Guillain Barré are severe and they require intensive care unit support and management. These are some of the publications that I'm going to use during my presentation. You mentioned that Guillain Barré syndrome is a syndrome that's celebrated 100 years of existence. The first publication was in 1916. At that time, it published patients who had peripheral neurologic involvement with to the point that it requires ventilatory support. This is the first publication, Guillain Barré, published by Dr. Guillain and Dr. Barré in a French journal, tried to explain a flaccid ascendant paresthesia, variants, and may have cephalic involvement and brainstem involvement. This is the evolution of Guillain Barré, the stages. There's an infectious phase with agents that such as Campylobacter and some immunological response. There is a progressive phase. There's a plateau phase that may last weeks to months, and there are recovery phase and stability may go up to 3 or 5 years, depending on how severe the case. As I mentioned, that the severe patients have a duration of up to 2 to 5 years. These are the patterns of neuronal involvement. In the left, you have the normal motor nerve with the axon, the normal appearance where we see the myelin sheath. In the right side, we see the two patterns, the demyelinating pattern and axon pattern, less severe than the axonal neuropathy. In the axonal presentation, there's a commitment of the axon, and therefore the involvement is quite severe, and the prognosis is difficult. We also mentioned the variants of the Guillain Barré syndrome, the classical commitment with quadriparesis, ascendant paralysis, the patient is awake. There are some other variants. Perhaps the most important variants are the Miller features and hemoplegia, ataxia. Patient has motor disability. The most complicated that we've seen is this Bickerstaff brainstem myelitis, and the patient is in coma, severe involvement, and we have to make a differential diagnosis to reach to this diagnosis. When we admit a patient with Guillain-Barré to our unit, we need to look at respiratory failure criteria. The most important are the clinical diagnosis. We know that this is a patient that had a gastrointestinal problem initially. There's been a progressive involvement with paralysis. The emergency that this patient will have respiratory involvement. We usually identify dyspnea, the use of accessory muscles, hypnia, with cardia or bradycardia, which is late. Arterial hypertension, secondary to the stress state that the patient is showing. There's anxiety. And once we have encephalopathy and somnolence, it's because this patient is in hypoventilation. There's narcosis, increased CO2, and also some neurovegetative manifestations as well as sweating. Patients are admitted to the ER and stabilized by the emergency doctor, make the diagnosis, and if the patient can be managed with spontaneous ventilation, we provide the indicated support, and we are always alert to when we're going to be transferred to the ICU. When we have ICU admission criteria, because this patient requires ventilatory mechanical support, and they have a very grim prognosis. Those who have a rapid presentation in less than 48 hours, and they also have dysautonomy. If you ask the patient if your palpitations, say yes, some many palpitations, and their cardiac rhythm with tachycardia and bradycardia. There's bulbar function, cannot elevate head and elbows, and there's an absence of the cough reflex. The patient has a viral capacity less than 20 milliliters per kilo, a Pmax of 30, and a Pmax of 40 milliliters of mercury. We also have some cardiovascular admission criteria to the ICU. The more severe cases with neurovegetative dysautonomy, up to 4 weeks after the symptoms were started, then they have hypertension, hypotension, tachycardia, bradycardia, ventricular arrhythmias, sudden death. The description of the huge scale with diagnosis of a patient with Guillain-Barré, grade 0, healthy and progressively at to grade 6, which is causing death with ventilatory insufficiency with neuro sudden. Grade 1, minor symptoms and bipolar running. Grade 2, able to walk 10 meters without assistance but unable to run. Grade 3, able to walk 10 meters across an open space with help. And in grade 4, the patient is bedridden or chair bound can't walk. Grade 5, patient requires assisted ventilation. And grade 6 is when the patient dies due to ventilatory insufficiency of neurovegetative complications. Therapy, if it has been mentioned, usually starts once we make the diagnosis of Guillain Barré. Patients come to the ER with 3 to 5 days history. We indicate immediate therapy, which consists of plasmapheresis or immunoglobulin, and there we have the dose per kilo, which is what we do with hospital with albumin 200 to 150 per kilo, plasmapheresis every other day, sessions, while the administration of immunoglobulin for 5 days at a dose of 0.4 grams per kilo. Total dose of 2 grams per kilo in 5 days. There's no difference in effectiveness, both treatments effective, there are only economic differences. The goal of this therapy will be circulating antibodies that are affecting the neurons in the case of immunoglobulin to eliminate the antibodies with neuronal involvement. This treatment requires some care and prevent complications. Who are on spontaneous ventilation not require ventilatory support may precipitate the start support doing plasma exchange, the coagulation impairment, electrolytic complications, hemodynamic complications. And as I mentioned, if the patient in respiratory, spontaneous respiratory, the first indication of respiratory failure following through a central venous catheter with a half flow catheter or French, where this will be done more adequately. We need to consider that plasmapheresis when you place the catheter has to be at least 12 hours before, because as I mentioned, they have coagulation, they have hematoma. The treatment with immunoglobulin, I think we need to be careful for allergic reactions, and we administer in perhaps the vials have 5 grams in a patient with 50 kilos, 20 to 25 grams per day. Each infusion is 1 vial per hour. This is how we do it for 5 days. These are the comparative studies between therapies of plasmapheresis, where they mentioned that in Japan, immunoglobulin therapy, no steroids, in Belgium the same. In first world countries, most of them use immunoglobulin. In countries of the third world, we still use steroids as and plasmapheresis and immunoglobulins to a lesser extent. European countries, where they follow protocols, is the use of immunoglobulin. We also compare in the regions in terms of the effectiveness or the need of supportive therapy or plasmapheresis or immunoglobulin therapy. They are indicated in the severe forms, where the likelihood of recovery has to be considered early between the first 2 weeks. In terms of intensive care, if there is respiratory failure, patient needs to be intubated and placed on a ventilator. The ventilation modalities are invasive, pressure or volume. This patient should not be severely sedated, just superficially. but some of them show neuropathic pain, and we need to treat them with other painkillers to prevent the collateral effects of opioids. We use multimodal analgesia with paracetamol, pregabalin, and low dose of opioid and light sedation together with other drugs have to be evaluated on a daily basis to see if the patient has improved and the ventilation. The mechanical ventilator not only offers oxygen flow, but also helps with pulmonary mechanical, and we do a daily evaluation. What happens is the patient for session of plasmapheresis on the fourth day of treatment with immunoglobulin, we see that there is no favorable response present, and we found that it's an axonal pattern, and we perform an early tracheostomy. This is to prove the condition because the endotracheal tube may produce some lesions in the upper airway in vocal cords. As I mentioned, this is not completely sedated, has a light sedation, and is quite uncomfortable to do in your mouth. So that's why we prioritize tracheostomy to picture. We do it when we failed therapy, where there's no favorable response on the fourth session of plasmapheresis or the fourth dose of the tracheotomy is on in the patient's bed in the ICU. And the advantage is that we can improve the communication with the patient. We can read their lips and we can communicate less anxiety, and there's much better communication. There's a reduction of complications such as delirium and infections. Yes. That in that early long-term ventilatory involvement is more beneficial. As we mentioned, the complications that we see in the autonomic dysfunction, tachycardia and bradycardia, arrhythmias. Up to the first or fourth week, we need to be very alert. These are patients that have more tachycardia than bradycardia. We administer some beta blockers to prevent tachycardia that may go up to higher 130, 150 beats per minute. They have also described the death to autonomic dysfunction. Usually these patients are hypertensive at the beginning, and then they show hypotension, block, ventricular arrhythmia, and then the possibility of recovery are quite poor. In intensive care, we need to prevent complications of a patient that is in mechanical ventilation, then pneumonia. That needs to be sitting, prevent the use of gastric protective. We place a nasogastric tube, gastroenteric, for early enteral nutrition, decontamination, and the endotracheal tube needs cyclotic aspiration to aspire all the secretions that may be cause of infections. We also prevent deep venous thrombosis. These patients are quadriplegic. They are bedridden. They may show DPT. Delirium also because these patients have a prolonged in ICU. It's devices with the sleep cycles. Uh,
los ojos también
we
para evitar
protect the
el IR,
eyes,
¿no? Se
we
baja arriba los
prevent the
monitores
light,
para evitar pues,
we
que
reduce
haya
the
un
noise
efecto
of the
lento,
monitors,
porque este
prevent
paciente
stress.
tengan en cuenta que está consciente, ¿no?
Consider
El
this
tema es
patient is
evidentemente motor,
awake.
se da cuenta de lo que sucede alrededor.
The issue is
Esta parte
motor,
también
and they
es
realize
muy
what's going
importante
on
pues
in their
que la
surroundings.
familia esté casi
Also, to make
permanentemente al lado
sure
del
that the
paciente, ¿no?
family is next to the
Obviamente
patient
se siente más cómodo,
because they feel more comfortable
más seguro, ¿no? Y se
or
oye una voz
safe
bastante amigable con la
and a
cual
friendly
puedan
voice.
intercambiar, digamos, algún tipo de sentimiento, ¿no? ¿Qué hacemos con
What
RVs
about
de labor mecánico,
weaning
¿no?
of mechanical
En estos
ventilation?
pacientes, en las formas severas,
In
hay
severe
fracaso
presentations
cardíaco,
where there's been a
fracaso
failure
enzimático o
of plasmapheresis or
se
immunotherapy,
ideal es hacer una traqueotomía precoz,
do an early
debemos
tracheostomy,
por lo menos estar alertas a
at
la
least to be
disautonomía, el
alert
uso
to the
de
presence of
inhibidores
dysautonomy,
de acción
the use of
covalente
beta
es
short-term beta
fundamental.
blockers, extremely important.
Necesitamos algún tipo de protocolo para,
Some
digamos, para un
protocol
manejo ventilatorio
for
en
the
pacientes
ventilatory
crónicos, tenemos un
management
par
of
de
chronic
protocolos, ¿no?
patients,
Hacemos
monitoring
oxigenación
protocol,
facial y hacemos una
to
terapia
bronchial
respiratoria y física de manera permanente,
hygiene,
¿no?
and physical and respiratory therapy on a
Sin
permanent.
embargo, estos pacientes no pueden quedarse
However, these
hospitalizados
patients
muchísimo
cannot
tiempo
stay for a
en
long
los
time
hospitales en
in
vista
our
de que
hospital
se someten a una ventilación mecánica prolongada.
because
La
prolonged
mayoría de los hospitales en
mechanical
Latinoamérica
ventilation. Most of
lo
the
hacemos
countries
en
in this
cuidados
country
intensivos o en
do
terapia
this. We
intermedia.
offer this mechanical
Sin
ventilation in
embargo,
intensive care
estos
unit or
pacientes pueden tener
intermediate care unit,
hospitalizaciones prolongadas que pueden llegar a
prolonged
6
hospitalizations,
meses, un año.
6 months or a year.
Entonces, lo que se plantea es hacer
That is why what we
lo que hemos
propose is to
llamado
do
home care, ¿no?
prolonged
En
mechanical
home care
ventilation
se
home care,
habilita una,
where
una
we
cama, un
organize a
ventilador
bed and a
domiciliario, personal que pueda asistir,
home mechanical
una
ventilator
suite en la cual que tenga bastante comodidad el
where
paciente
the patient can be
y pues ahí se asiste a través del personal de salud, ¿no? Esto
health
ayuda
staff.
mucho a
That
tratar
helps
de filtrar a los
a
pacientes que
lot
están
in
de manera crónica en nuestros hospitales.
treating
También
patients
el
who are
home care
otherwise
ayuda
will
a
stay
que haya
long
un apoyo
time in
emocional,
our
familiar,
hospital. They
asistencial
also need family
y
emotional
sobre
support
todo volver a
and
la comodidad del hogar, ¿no? De donde salió
be at the comfort of their
después de que
home.
estuvo hospitalizado muchísimo
That
tiempo
patient has been hospitalized for too
en
long
nuestros hospitales.
in our hospital.
Las conclusiones serían que el síndrome de
Are the
Guillain-Barré
following:
en sus formas
Guillain-Barré syndrome in a severe
neurológicas
form,
que requieren internamiento
neurological emergency that requires
intensivo,
monitoring and support
está
measures
asociada
at the
con
ICU. There are
procalcito
standardized
hemático e
treatments
inmunoglobulina
with plasmapheresis and
y
immunoglobulin.
en paralelo la medida de soporte y
Support
monitoring
measures
para
and
mejorar el
monitor
pronóstico.
measures are vital to
La
improve
terapia física y la
prognosis.
rehabilitación son necesarias
Physical
en
and
socorro
rehabilitation
y
therapy are
traqueotomía
necessary
por
and
vía
should be
aérea
done
también es
early.
necesaria en pacientes que
Tracheostomy
están con
is
monitores de ventilación
necessary in
prolongada
patients who have a
y en home care
prediction of
los
prolonged
cuidados intensivos
mechanical
reducen
ventilation.
complicaciones
In
infecciosas
home care,
y el
reduces
estado
infectious
mental
complications
de
and
los
improve the
pacientes.
mental status of the patient.
Bueno, esa es mi,
Well, that
mi
was
contribución
my
a este webinar.
contribution
Quizás
to
en
this
algunas
webinar,
preguntas podamos
and
responder
I
las inquietudes
gladly answer
de
all
los
the
participantes.
questions.
Muchas gracias.
Thank you.
Excelente, estimado doctor Verde.
Excellent, Dr.
Creo que
Valverde Guaman, for
la
your
presentación,
presentation.
creo que uno de los puntos más
I think that one of
importantes
the
que
most
ha
important
tratado
topics that
es
you have
relacionado
highlighted is
con los
related
criterios que hay
to
que
the
tener presente
criteria that we need to
cuando se va a
present.
internar a un paciente.
We're going to admit a
Esto
patient,
también va
and
acompañado de
that also
criterios
comes together with the
cardiovasculares,
cardiovascular
taquicardia,
criteria such as
bradicardia,
bradycardia, tachycardia,
hipertensión,
hypertension,
hipotensión y la disautonomía
and
neurovegetativa. Un
neurovegetative
punto importante que
autonomy.
ha subrayado usted está
Something important
relacionado
that
con
you
la
mentioned
permanencia del paciente
related to the
en,
state of the
cuando
patient
tienen complicaciones
when they
que
have
van a tener un tiempo de
complications that
recuperación.
require a long
Esto
time for recovery,
promueve los cuidados
or you
intensivos
promote home
favorecidos por
that
el apoyo emocional que da la familia, también
have
la
the
comodidad
value
de
of
estar
emotional support from the
en
family, the
turno,
comfort of being
la
at home,
disminución del riesgo de
and the
tener
decrease of the risk of
complicaciones
having
hospitalarias que a veces
hospital complications
darían dificultades en una
that
recuperación
will
del paciente.
be
Bien,
interfere with
estimado
the patient's
doctor,
recovery. Dear
entonces vamos a
Dr.
pasar a
Valverde,
la
we're going
parte
to move
de
on
preguntas.
to the Q&A.
Invitaría a todos los
We will
presentes
invite all of you
que prendan sus cámaras
to activate
para poder compartir el
turn on your
espacio.
cameras. Or
Desde ya hacemos un
we
agradecimiento
would like to
a todas
thank
las personas con
all
respectivos
those
saludos
who have joined us from the Ministry of Health,
a las personas de la academia,
people from the academic area, different entities and social
a
organizations,
las personas que se han conectado
people
desde
who have
Argentina,
connected from
Belice,
Argentina, Belize, Bolivia,
Chile,
Chile, Colombia, Cuba,
Ecuador,
Ecuador,
España,
Spain,
Guatemala,
Guatemala,
Inglaterra, México,
UK,
Nicaragua,
Mexico, Nicaragua, Paraguay,
Uruguay
Peru,
y
Uruguay,
Venezuela.
Venezuela.
Asimismo, quiero
Likewise,
resaltar
I would like to highlight
el acompañamiento de nuestros compañeros
our
del
friends from
organismo
the
de
Andean
salud.
Health Organization
Bien, para iniciar las preguntas,
to start this dialogue
invitaría al
and
doctor
the
César
questions
Munaico
and Dr. Munaico
para la siguiente
for the following question.
¿Cuáles son las
What
hipótesis
are the
que explican la
that
mayor
explain
concentración de
the
casos
higher
en
concentration of cases in
Lambayeque,
Lima,
La Libertad
Lambayeque,
y
La
Cajamarca?
Libertad, and Cajamarca?
Adelante.
Go ahead, please.
Doctor César,
Dr. Cesar,
está con su micrófono apagado.
you need
Doctor,
to you need to mute your microphone, please.
bueno, seguimos.
Well, we will move on.
Es una pregunta para
This is
el
a question
doctor
for Dr.
Valverde y también para el
Valverde
doctor
and for Dr. Santos.
¿Qué hacer para propiciar
What do we
un
do
mejor
to
pronóstico
promote
en
a
casos
better
similares
prognosis in cases
de
of
la
Guillain
clínica
Barré
y de los determinantes
and the
sociales?
clinical and social determinants of
Adelante.
health? Please go ahead.
Adelante, doctor Santos. Y
Go ahead, Dr. Santos, and then Dr. Valverde.
Bueno,
Well,
una de las factores que más van a
one of the
contribuir
factors that are going to
a
contribute
mejores resultados es
a
el
better
diagnóstico.
outcomes
Pues,
early diagnosis.
mientras más nosotros seamos capaces de
The
diagnosticar
earlier
los
the
casos,
diagnosis and identification of cases in the initial
proceso para
stages
iniciar un tratamiento,
and
en
treatment,
esa fase los
in this
resultados van
phase,
a ser
the outcomes are going to
van a
be
ser más efectivos.
more effective.
La vigilancia estricta de los casos
Strict surveillance of cases that we know that may have an adverse course because of all the elements that we have already mentioned is important, especially in those patients where in early stages are going to start to present signs of symptoms of respiratory failure with neuromuscular involvement that require ventilation to stratify these cases and take the adequate therapeutic measures as early as possible. These are the most recommended elements, right, to decrease the complications and the negative consequences of patients who survive these conditions. By that, we all have cases that no matter how effective we are in treatment, and they complicated, and some of them die. I don't know if this responds to the question.
Gracias, gracias, doctor.
Thank you,
Adelante,
Doctor.
Valverde.
Go ahead, Dr. Valverde.
Sí, creo que la
Yes,
educación
in that education
se está planteando para conocer de manera precoz a
to
través de
do an
todas las
early
redes de
diagnosis through
es muy
mass
importante
media is
porque
very
puede dar
important,
alerta
because
a
with
la población,
this
pero
we can
también puede
alert the
ser una situación
populations
de brote
that we are in a
y esto
situation of an
podría,
outbreak,
digamos, hacer que estos
and
pacientes
that can make
se sientan con síntomas
patients
clínicos
who have neurological
acudir de manera
symptoms
temprana a un centro de
go
salud.
early to a health
Es
facility.
importante que se diagnostique de
It's
manera
important
precoz
to
para
do
evitar
early
estos síntomas.
diagnosis to have better
Es
prognosis.
importante que el paciente
Important that the patient
reconozca los primeros síntomas para
know
poder acudir.
recognizes the
Y esto es lo
first
que veo
initial
en la primera
symptoms.
difusión que se están haciendo hoy en día
Some of the
en la
discussions that
población.
we are doing in the
Me parece
Ministry
muy
of Health.
importante que la educación,
I think that
más que todo después de
health
la pandemia,
education
ha
after the
tenido un
pandemic
impacto
have had
porque
a
hoy día
great impact
la población en Perú
the population in Peru is quite concerned and
de
face
emergencias sanitarias.
any type of sanitary emergencies, like we call this
Complicaciones en este
way we can
caso,
prevent
están
many
en el centro de
complications.
día cuando está
Is
complicado.
arriving late to a health facility when
El
and it's
diagnóstico precoz es
complicated.
fundamental
So
para que
early
exista
diagnosis,
éxito en esta
fundamental.
Gracias, doctor.
Thank you.
Una segunda pregunta.
A second
¿Por qué
question.
motivos los casos
Why
más frecuentes en
do
población
cases are more
de más de
frequent
40
in cases between 40 and
para
20 and 40 years of
Gracias,
age?
doctor Santos.
For both of you, Dr. Santos, you go first, please.
Bueno,
Well,
eso es una pregunta un poco
this is a
de
difficult
que
question to answer.
lo cierto es que,
The truth is,
a ver, muchos de los pacientes que
many of the
se sabe
patients,
que estas enfermedades que son mediadas
because we know that
inmunológicamente,
these
hay que tener en cuenta
immunologically
tanto
mediated
factores
diseases, we need to consider
proceso infeccioso, o sea,
several
de la
factors of the
causa,
infectious process of the
como
cultural agent,
elementos del huésped.
as well as elements of the host.
No todos los pacientes que hacen una
Not
infección
all
van a
patient who has an
desarrollar
infection is going
la
to
enfermedad,
develop
o sea,
a
ya sea
disease,
un
is
síndrome
going to
de
develop a
otro
syndrome of
síndrome
Guillain-Barré
inflamatorio
or a
inmunológico. Hay
neuroinflammatory
algunos
syndrome.
estudios que hablan de
Some
ciertas
studies that
predisposiciones
mention that
genéticas,
some
eso
genetic
obviamente tiene que ver
susceptibility
con el sistema mayor
does
disponible,
have to do with this compatibility measure system.
estudios que se han hecho sobre eso y
And
al
studies
parecer
made with this, and it
cierta
seems that
población
there are some
vulnerable,
populations that are
por
vulnerable
decirlo de alguna manera, ante algún
to
proceso
say it in
infeccioso
some
que
way
a su
that
vez
in
desarrollen
an infectious
un
disease they can
síndrome.
develop a
Lo
Guillain-Barré
cierto es
syndrome.
que las personas
The truth is
de
that
mayor edad
people in the older age
suelen ser las que pueden tener
are those
mayor
who can
susceptibilidad
have a
y
greater
también
susceptibility
en este grupo de
because
personas
in this
pueden
group of
coexistir
people
otras
they may
patologías, pueden
coexist with
coexistir
other
otras
pathologies,
enfermedades
other
y que
conditions.
una vez que se adquiera la enfermedad, pues
Once they
la
acquire
evolución
the
puede
disease,
ser diferente.
their course can be
Pero en
different.
niños también
And in children
existen casos
also, we can see
de síndrome de Guillain-Barré
cases of
con la
Guillain-Barré
misma frecuencia
syndrome
que se ven en
with
los
the same
adultos.
frequency that we
En
see
el
in
caso
adults.
de las combinaciones donde
In
puede
the
haber
case
una
of
afectación del
combinations where they
nervio o
may
el músculo
both of
secundaria a
muscle
nivel
and nerve
periférico, eso
involvement, we
puede
see more in
aumentar
children.
el síndrome,
I mentioned
las
before,
afectaciones estas de tallo cerebral se ven
the
también muy
brainstem
frecuentes en los niños, aunque no son
involvement
muy
is
frecuentes.
frequently seen in children
Esa es
too.
una de las posibles
One of
hipótesis
the
que pueda
possible
responder esa pregunta.
can respond.
Muy amable. Gracias. Adelante, doctor.
Thank you, Dr. Santos. Go ahead, Dr. Valverde.
Bueno, los extremos de la vida siempre han sido
Well, the life
vulnerables
extremes have always been
a factores
vulnerable
inmunológicos,
to
¿no?
immunological
El
conditions.
paciente joven, el niño,
The young child
tiene un sistema inmunológico
has
bastante
immature
vulnerable,
immunological system, and in the elderly,
comorbilidades, eso también lo debilita.
other comorbidities that
Eso lo hemos visto
make
en
them
los últimos
weaker.
años, ¿no? Lo hemos visto
And we had that, as we saw in the
los adultos
pandemic,
mayores han sido los más vulnerables.
that these extremes of
En el
life were the
caso
vulnerable.
del joven que tiene 20,
In the
30
case
años,
of the
40 años,
patient between
y en la cual pues
20 and
usted
40
ve
years,
que no es vulnerable a este tipo
which is not vulnerable
de síndrome,
to this type of syndrome,
es bastante osado, ¿no? O sea,
is quite
yo
bold.
recuerdo mucho
I
en
remember
la pandemia cuando comenzamos a
the
tener
pandemic when we start having
comenzar a
young
tener
adults
complicaciones
who
y
start showing
que
complications.
no utilizaba
Was
mascarilla, no tenía medidas
they
de
didn't wear a
prevención,
mask, no
se
infection
sentía
control measures.
que la vitalidad que
They
tenían
felt
durante días
that they were
a
quite
que el
strong.
virus los pueda golpear, por
They
ejemplo,
could not be hit
si no
by a
tenemos
virus, but that was
medidas
not the
preventivas,
case.
obviamente cualquiera de
If
estos
we don't have
es
preventive
vulnerable
measures, everyone can be vulnerable
a este síndrome, en este
to
caso
this
Guillain-Barré, y pues
Guillain-Barré,
sobre todo si no
especially
creemos
if
en
we
la
don't
prevención.
believe in
Entonces,
active
tenemos
measures.
ahí el caso de
So
estos
we
adultos
see the case
mayores
of young
que pudieran
adults
tener estas
that
complicaciones
may have
más aún
show these
por el
complications,
tema
not
inmunológico, ¿no?
because of
Se sienten un
immunology,
poco vulnerables
but
a
because they
este
feel
síndrome.
that they're not vulnerable.
Muy amable, doctor
Thank
Valverde.
you, Dr. Valverde.
Pediría ya para el
Will
cierre
ask
de esta
to
reunión
close this meeting
que nos den una
to
reflexión
give us
final,
a final
invitando al doctor
comment.
Ángel
We invite
Miguel
first
Rodríguez.
Dr. Angel Miguel
Adelante, doctor.
about this process. Go ahead, Dr. Santos.
Bueno, yo creo que
Well, I think
una de las cosas que
that
tenemos
one
que
of the things
reflexionar
that
sobre
we
estas
need to
patologías
reflect
es
on
que
this pathology,
los sistemas de salud tienen
that
que
health
estos
systems,
brotes epidémicos que se
when
generan
they face these
síndrome de
outbreaks,
Guillain-Barré
of Guillain Barré related to infectious process, either viral or diarrheal disease, have to be well prepared and equipped. Because although the largest number of patients recover and had a good evolution, there are always going to be some cases that that's not going to be the case. Another of the elements is the health staff, both physicians and nurses and staff need to be trained in caring for this type of patients. I've seen that while the cases are seen in discuss among specialists and in groups, the patient is always going to benefit more because in those medical discussions of these cases, they always benefit the physicians and the patients with this multidisciplinary approach. And that will be very positive when we treat these patients. And in terms of the preventive measures towards the population, consider always the measures that offer guidance on how to contain the epidemic, try to avoid acquired and infectious diseases. Sometimes we have an infections and most of these are asymptomatic, and despite that we develop a syndrome as this one. But as long as we can avoid acquiring one of these like arboviruses, they call the hygienic measures to prevent the proliferation of this mosquito. It will also be something important for people's education.
Muchas gracias. Adelante, doctor.
Thank you,
Valverde.
Dr. Valverde.
Me parece que hay puntos importantes como la prevención,
Prevention is very important
cortar esa cadena
to
de continuidad
interrupt this chain of continuity with regards
infecciosa
to
fundamental,
infectious
lavado
disease
de manos, ¿no?
and their progression with
Importantísimo el uso.
measures such as hand washing.
Luego, en cuanto
And
a
then,
lo que es recursos
in
humanos,
terms of human resources,
obviamente al personal de
train
primer nivel para
all the
reconocer
first level staff to recognize and identify
y
cycle syndromes,
obviamente pues tener
and
una
then
logística adecuada en los hospitales,
adequate logistics for hospitals,
tener inmunoglobulina como ha comprado el
have
hospital,
immunoglobulins available,
tener la logística adecuada,
and adequate
prepararse
logistics,
pues para planes de
and be
contingencia
ready for
importantes, ¿no?
plan.
En el caso de Guillain Barré en la forma grave,
Case
pues,
of Guillain Barré near severe
unidades de soporte ventilatorio en altura,
ventilatory support
digamos,
units
poder recibir la cantidad de pacientes
so we can
que se
treat
necesiten, ¿no?
who need it.
Y obviamente estamos a
And
disposición de
we
de
are,
todas
of
las
course,
personas. Creo que eso también
to
es importante
educate people
para poder evitar pues este tipo de
in order to
complicaciones
prevent this type
futuras
of
de Guillain-Barré.
Guillain-Barré syndrome.
Muchas gracias.
Thank you,
Estimado doctor
Dr.
Santos y doctor
Santos and
Valverde.
Valverde.
Estamos muy agradecidos por el
We're very
espacio
thankful for the
brindado
time that you
por
have
sus
given us,
conocimientos,
for
por
your knowledge,
compartir
and
sus
for sharing
experiencias
your
en diferentes
experiences
ámbitos
in
de
different
las Américas
areas
y
of the
además
Americas,
también por
and also
las recomendaciones que nos da.
following the recommendation.
Quiero hacer una
I
mención
would like to
especial al
mention
doctor
Dr.
Moya,
Moya,
médico
who is
epidemiólogo
a
mexicano,
epidemiologist,
en este momento
who at this
es
moment
representante
a
de la
representative
OPS
of
en Cuba,
PAHO in
que nos
Cuba,
ha brindado las
who
facilidades
has offered us the
e
possibility
instalaciones también para
and
que
facilities
tengamos la
we can
participación
have the
del doctor
participation
Santos.
of Dr. Sant.
Sin más, un fuerte abrazo y quiero
And
darle la palabra, la
I also will
oportunidad
give the floor to
para el
Dr. Maria del
cierre
Carmen
de
Calle
este webinar.
for
Adelante, doctor.
closing this webinar. Go ahead, Dr. Maria del
Bueno,
Carmen Calle.
mis primeras
Well, my
palabras son de
first words are to
agradecimiento,
thank
doctor Santos,
Dr.
doctor
Santos, Dr.
Valverde, doctor
Valverde,
Monaico,
Dr.
por
Monaico
habernos permitido, haber
for
tomado un poco de su tiempo para
giving us
darnos
part of your
ayuda en
time to give us an update.
síndrome que nos está
This
preocupando.
syndrome that is of great concern to us.
Primeramente, con los conocimientos que se han
With
vertido,
the knowledge, with the information you have provided,
se tomarán mejores
we will
decisiones.
make
El síndrome
better
requiere
decisions. I would also like to thank
disponibilidad de nuestros
the presence of
participantes, ¿no?
our
Estamos
participants,
están llegando más o menos
that
400
we get
personas,
up to 400
de las
people
cuales
participating.
principalmente contamos con
We mostly have general practitioners and nurses. The idea behind this seminar that we started 3 years ago is to take the information to the largest amount of people possible. And Guillain Barré is important. I've spoken about prevention, the presentation, you've spoken about the importance of early diagnosis and to have the adequate treatment and support. We were surprised, Dr. Valverde, that you tell us that 20% goes to the ICU, and that 20% of all the, what is the denominator in this 20%? Because 20% is a large. I wanted to ask Dr. Valverde, in page 20%, you mentioned 20% requires IC intensive care units. Of those admitted to the hospital? Yes. Not necessarily patients who require ventilatory support, but monitoring. Not all of them have respiratory failure because with the issue of sudden death that we can see sometimes. Once a patient is stable, they leave the unit, they go to the ward. Okay, because to talk about 20%, think in ventilators and it's an extremely high number. But what you mentioned is also important, that this is a syndrome that always gets to ICU. You always have this type of patients, which is what we discovered because we also had an outbreak in 2017. But I work at the Ministry of Health, and we also had this outbreak in the coast, and also with the same characteristics that have been mentioned, with the difference that now we have better options and more early diagnosis. Thank you very much. On behalf of the Andean Health Organization, the Politinano Agreement, these webinars, what we want to spread the information. After these webinars, we have technical meetings, and the technical meetings are with the focal points of 6 countries. We work with the Ministry of Health of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. And for each topic, for each area, we have the focal points, which are the technicians that we meet. Thank you very much once again. And we should not forget to invite you to the next webinar this Thursday, July 20 at 11 a.m. We are opening a special section of webinars called Special Series, International Innovations in Health. So we're going to present the most recent advances in some diseases and conditions, and we have decided to start this Thursday with how are we doing with regards to leukemias. We're going to have experts from the US, Spain, and Peru to discuss on this topic. Thank you very much, Lucho, to all the Andean Health Organization. See you soon. Good evening.